welcome to everybody to this exciting seminar series called Ending TB in Our Time. I'm Violet Chiota from the Oram Institute. I have a very simple task of moderating the session, and I do look forward to the session this afternoon. And so we will start the session. I'll just give a brief overview of TB for those of us who are not working in the TB field. I primarily work in TB and TB-HIV co-infection. And so just to start off the series, I think we all know about the burden of TB. For those of you who don't, we're seeing at least 10.6 million people getting infected with TB annually. That's globally. And in South Africa, we'll get to hear more details from the presenters. And so to this end, what the WHO has done is to then have an end TB strategy. And the goal of the strategy is really to end the global TB epidemic. And this strategy was endorsed at the 67th World Health Assembly in 2014. And so there's been milestones along the way. And so basically the goal is to reduce TB incidence by 90% by 2035. So that's where we are aiming to be in 2035. We're currently in 2024. There are targets for 2025. And again, the presentations will kind of give you a sense of where things are at. And then just in terms of the end TB strategy itself, so what we kind of need to do, or the desired decline in the global TB incidence, for us to reach the 2035 targets, there's certain things that we have to do. We currently have a lot of tools for diagnostics, for treatment, and also for prevention that are already available. And so there's need to accelerate use of those tools just to help us really move from this very slow decline we saw post-2015. So we were sitting at 2% decline in TB incidence, and yet we needed to be at about 10% decline by 2025. So it's really been a tall order, and there's been several interventions that have been implemented. But again, when you look at where we want to be 2035, clearly the tools we have are not adequate. And so there's a lot of work going into development of new drugs, new vaccines, and new diagnostics. And we'll get to hear a lot about this in the presentations. And just as we thought we understood TB, this is my last slide, just to give people an overview of our understanding of TB. And I think we've always thought of TB as two-dimensional, so where you have TB infection and disease. But in recent years, we've really now understood that it's a spectrum of disease, and one moving from infection to active TB. And I think most importantly, I don't have a pointer, but most importantly, the subclinical TB has recently been defined and the definitions agreed on. And this is where people present with no symptoms of TB. So your usual cough, fever, weight loss, they do not present with those, or they may present with minimal symptoms, so they do not necessarily report them. But when you do a TB test, then they are diagnosed with a positive TB result. And so the spectrum has changed over the years, and in fact, even more recently, we now know that there is what we call incipient TB in between latent infection and subclinical TB disease. This is really just almost like a grading of the disease appearance, and it's based on clinical presentation, and it's also dependent on, you'll then get different radiological presentations. And so this really helps us understand some of the work that has gone into developing new, especially diagnostic tools. We'll get to hear a lot more about alternative tools that can be used in people who do not necessarily have sputum. And then we also have new diagnostics coming up, shorter regimens for diagnostics. So shorter regimens for TB disease. And so in terms of subclinical TB, one would ask, do you need a long 6-month regimen of TB, or would a shorter regimen work? So these are the discussions that we are having around TB. And I will stop there. I just thought to give context so you can understand and also, get a sense of the presentations that are coming. So we have a total of 4 presentations. The first 2 are going to be focused on a new strategy for case finding, which is called Targeted Universal Testing for TB. Prof. Neil Martinson and Prof. Dimakatso Lebina will present on the TAT approach. And then we're going to hear a presentation from Mama Pudi, who's going to talk about the modeling and costing, so basically looking at interventions that have been implemented or are being considered in South Africa and then costing those. And lastly, we're going to have a talk from Lena here around alternative sample types for TB. So our talk on TAT is going to be presented by Prof. Neil Martinson. And what I was going to say is we'll have all presentations, so please take note of questions that you may have, then we'll have a Q&A session at the end.
Okay, thank you very much, Violet, and thank you all for coming this afternoon to hear a bit about ending TB in our lifetime. Maybe not in my lifetime, but hopefully in the more younger part of the audience's lifetime. So really this graphic on the right-hand side of the screen highlights the proportion of people who have TB in the community, which is on the bar on the left, and over here is the group of people who get diagnosed, who get started on TB treatment and actually finish their TB treatment successfully. And you can see that in the order of about 220,000 people in South Africa remain undiagnosed with TB or uncompleted their TB treatment, a large proportion of whom never get even tested for TB. And so the WHO, in an attempt to try and address this group of so-called missing patients, the WHO has put out this guidelines for screening for tuberculosis. And in essence, they talk about systematic screening for TB, which is screening high-risk groups, every person in a high-risk group for TB. And this is a great departure from what was previously done with TB, which was allowing people to earn, in inverted commas, earn their test for tuberculosis by coming to the clinic and saying, I've got loss of weight, I've got fever, I've got cough, I've got night sweats, I'm coughing up blood, I'm near death's door. Before the clinicians would be prompted to take a sputum specimen. And so this, trying to look at other ways to diagnose TB earlier is clearly of importance. And so the W4SS stands for the World Health Organization's 4 symptom screening questions, which is loss of weight. Do you have loss of weight? Do you have fever? Do you have night sweats? Do you have a cough? And if you have any one of those, in the old days, that used to prompt, and even now prompts people to take usually a sputum specimen to investigate someone to see if they have TB. Now, clearly, there are other ways, and one of the ways that is being touted is this chest X-ray using computer-aided diagnostics as a way to stratify people's X-rays into an X-ray that is suggestive of tuberculosis to those that are not suggestive of tuberculosis. And that's being done in South Africa already in some select sites where people are being pushed through X-ray screening to determine whether or not that they should be tested for TB. Then the CRP, the C-reactive protein, which the clinicians will know about, is also used as a way of funneling or identifying people at much higher risk of having TB. Then there's a gene signature, which was widely touted, but in clinical trials has not been shown to be of real value. And these 4 things, the symptom screening, the chest X-ray, the CRP, and the gene signature, are all designed to try and reduce the number of tests that we do for tuberculosis. So everyone talks about the number needed to be tested, and if you have a lower number needed to be tested to find one patient with TB, then that's successful. And so we're thinking about turning that on its head and saying, okay, well, if we have this huge problem with TB, and in South Africa, the annual incidence of TB is going down every year, and if we want to end TB, we have to do things differently. We have to, the law of diminishing returns in economics means that we have to do things differently, and we have to do things more efficiently, and we have to change the way we're doing things. And so we're thinking about testing everybody, not testing only a few groups of people who have earned the right to be tested because of their symptoms. And so another thing that as Violet alluded to, is this is definition of TB disease, which is usually characterized by clinical manifestations. And so increasingly people are realizing that clinical manifestations don't distinguish someone who's infectious or not. And if we want to end TB, we really have to find infectious people before they infect too many other people, and get them on treatment as soon as possible. So just to think about with this systematic screening, people at high risk, who's at high risk for TB? And this paper sort of gives you these undernutrition, HIV infection, cigarette smoking, diabetes, alcohol use. And if you had to put them all together in South Africa, you'd probably be testing everybody. And then the WHO puts out in its annual report, the number of people in South Africa who contribute to the TB burden. And similarly, these are somewhat difficult things to really apply in practice. A large proportion of people who have diabetes aren't diagnosed. The number of people who smoke in South Africa is very high, and particularly men smoke a lot. But men in South Africa don't smoke large amounts of cigarettes, so they may smoke between 5 and 10 cigarettes a day, and does that really increase your risk of tuberculosis? And should you be targeting men who smoke or people who smoke, predominantly men? Alcohol use disorders, how easy is it to make a diagnosis of an alcohol use disorder? If you go around and question people, do you drink too much? Do you fulfill the requirements of these verbal questionnaires that they use to identify people who drink a lot? How easy is that to do, to identify people who should be tested for TB? Clearly, people who are living with HIV, it's relatively easy in this day and age to identify large numbers of people living with HIV and to test them. But what benefit is that? And in South Africa, there are multiple other groups of people, and I've just highlighted here a sort of extensive list, and whenever I speak to people, I try and add more. And so someone told me about people who cough anything. So if you say if someone is able to cough out a specimen, then should we include that? If you're able to cough out a specimen, is that someone at risk of TB? And what was the other one? And then children who are admitted to hospital with lower respiratory tract infection, possibly we could include here as risk groups at risk for TB. The mothers that accompany children who are admitted to hospital with lower respiratory tract infection are also at high risk for TB. And so this list we could carry on, and could we test all of these individuals? So one of the consequences of missing TB is obviously death, and we have been involved in this minimally invasive autopsy studies, and in 2012 we went to people who had died at home without an apparent cause of death. So if you brought the body to a medical practitioner and you said, please write the death certificate, we would roll the body over, look for a gunshot, a knife wound or something else. We'd say, what happened to this person? Oh, they were ill and then they died. And we'd write on the death certificate, died of natural causes. And so natural causes are really a garbage term. They mean nothing. You can't, how do you prevent a natural death? And some people might write cardiorespiratory failure, and that's also a garbage term, because you can't really prevent cardiorespiratory failure because all deaths are associated with cardiorespiratory failure. So we did this to try and find out what proportion of people died at home who didn't have a previous admission to hospital, who didn't have a diagnosis of TB in the past 2 months, and who would have in the natural course of events, would have had a death certificate that had a garbage term. And in South Africa, about 30% of people die at home, and in other countries in sub-Saharan Africa, it's much higher, closer to 50% of people die at home. And so we did the first study in 2012, and we found that 31% of people appeared to have TB in their lungs, so probably had infectious pulmonary TB. And then we did it again in 2020 at the time of COVID. Half of the patients were recruited before COVID and half while there was COVID, and we found about 7% had TB, and that suggests that the National TB Control Program is really doing something. Although this isn't beautiful statistics, and it's not thousands of people, and it's only in one district of South Africa, but it does suggest that if you go from 31% who died with evidence of pulmonary TB at the time of death to 7%, it does suggest that things are improving, and probably this is related to increased testing, better testing, antiretrovirals, 2 million RDP houses being built, a vast number of people getting a social grant, and probably some other things that I haven't mentioned. But also remember that people who die at home have these catastrophic costs, and you'll remember from what Violet had said that one of the ending TB goals is to try and reduce catastrophic costs for families. So what did we do, which is what I want to share with you today, myself and Dr. Labina, who will be talking after me, is we did this targeted universal testing for patients who attended clinics. And so we call it TUT, and this is Tutankhamun, shortened to TUT, just to remind you. And there's also this Christopher Robin. I don't know how many people were brought up reading Christopher Robin, but he said TUT, TUT, TUT. But anyway, so in essence, what is TUT? So in the TUT sort of strategy, everyone in a risk group is asked to produce a sputum. And so we go about it by asking people to wash out their mouth and then hopefully cough out an oyster. And if they don't have symptoms or they're unable to cough out an oyster, we just encourage people to have a repeat cough effort and spit whatever's in their mouth into the bottle and repeat this 2 or 3 times until we have about 3 mils of either oyster or 3 mils of saliva. And in this TUT thing, we subjected all to this Expert Ultra, which, as the clinicians here know, has been recently rolled out as the most recent, not the most recent, but one of the assays that are used to diagnose TB in South Africa. And in most clinics of South Africa, you can get a result in 48 hours. And if it's positive, you usually start on TB treatment within about 2 or 3 days. And so in this study, we subjected all to both the Ultra as well as to a liquid mycobacterial culture called midget. And so one specimen we took from each person, it was divided into 2, one for culture, one for Ultra. Because our concern was that the Ultra was less sensitive in people who didn't have symptoms. And in people with HIV, these molecular assays are usually less sensitive than in people who are seronegative. And so really the overall objective of this was to see if augmenting routine symptom screening with universal testing in groups at high risk of TB would give a better yield of TB diagnoses. And the people that we targeted were people living with HIV, were people who reported. They just had to tell us that they had a close contact with someone with TB in the past year. And finally, people with prior TB. And the reason why we use these 3 groups is that people living with HIV living with HIV is the most potent risk factor for TB that we are aware of. Being a close contact of someone with TB in the past year gives you a much higher risk of having TB disease. And then if you were diagnosed with TB in the past 2 years, you're very high likelihood of having a second episode. And so we didn't say, were you treated with TB in the past 2 years? We said, were you diagnosed? Did someone tell you you had TB in the past 2 years? So it's slightly nuanced thing, but in South Africa, a lot of people get diagnosed with TB, and approximately 25% of people who are diagnosed with TB haven't started their TB treatment within a month of being diagnosed with TB. And so that's a horrible inefficiency in the system, And this is one way to pick up the inefficiency of the health system in getting people diagnosed with TB onto treatment. And so we then consented a whole bunch of people who fulfilled these criteria, and we took 60 clinics in 62 clinics in 3 provinces of South Africa, and they were randomized to receive either this thing or to receive the standard of care, just carry on whatever they were doing, which was usually symptom-based testing. And so these are the 30 primary healthcare facilities that got the standard of care. And these are the ones that had the study intervention. And you can see the number of tests that we do is not, we don't want to reduce the number of tests. We expanded the number of tests to try and test more people and not have a funnel that said, okay, well, you guys get excluded because you don't have a CRP or you don't have a chest x-ray that's positive or whatever. We just tested everyone who consented. And so in this part of the talk, I'll be describing the people in the intervention clinics only, and in the next part, Dr. Labina will be talking about the results of the trial in terms of comparing the 2 arms. And so these are the people that we consented. We consented something like, I think actually this is slightly incorrect. We consented about 32,000 people. We were able to get a specimen out of 30,000. So this idea of if you can't give an oyster or if you say I can't produce anything, we were able to get specimens from the vast majority of people who we consented. And you can see the median age 39, as per the sort of clinic attendances in South Africa, primarily women. And then you can see how many were symptomatic. So under the normal course of events, only 28% of these individuals would have been tested. We tested a much larger proportion. Most of them were living, so these are our 3 groups. People living with HIV, whether TB contact or prior TB, and you can see the different risk factors that people fitted into. And you can see that it's way more than 100% because obviously people are in 2 groups. You know, you can be living with HIV, be a close contact, and have prior TB in the past 2 years. And so this is just doing a similar thing, but giving, saying what proportion was in each group. And then our yield results. So this is saying what proportion were positive. When we talk about yield, we're talking about what proportion were positive. So overall in the study, 6% were positive. Over here, 6% were positive. And the number needed to be tested was 17. So 17 people were tested before we got 1 person positive. In people living with HIV, we'd need to test 20 people to get 1 person positive. In contacts, we'd need to test 13 people to get 1 positive. And this rather surprising thing that we found, you'd need to test 8 people who said they had TB before to get 1 positive. And here are some of the risk factors, and you can see being male, all over the world, being male is more likely to have TB. If you're HIV infected, surprisingly, this was actually protective, but I think it was because of the vast dilution of the number of people who were living with HIV. If you had prior TB, 2.1 times. If you lived in KwaZulu-Natal, much higher than in Gauteng. If you lived in Western Cape, also much higher than in Gauteng. And so this also summarizes the data similarly. These blue columns are the number of people that were tested. This is then divided by whether they were symptomatic or asymptomatic. And you can see that the asymptomatic in all of these groups, so this is overall, this is people living with HIV. These 3 are living with HIV. These are people with contacts. And these are people who had prior TB. And you can see the relative contribution of prior TB to TB contacts to living with HIV. And so targeting people living with HIV really finds the most number of patients. This is the proportion of people that were positive. And you can see that, as I've just mentioned, the people who had prior TB had a much higher proportion that were positive. But the vast number of people that, if you're looking to try and impact TB, you'd probably focus on these individuals here. Now remember, the key thing about this is that we only target on 3 risk groups: living with HIV, people who had a TB contact, and those with prior TB. And you'll remember that other slide that I had. There's this long list of other risk factors for having TB, and maybe if you targeted them, you'd also find similar numbers. So anyway, that's as far as I'll go. And Violet, thank you very much, and I hope I haven't
introduce Neil properly. And so just to say, Neil he heads the Perinatal HIV unit, which is part of the Wits Health Consortium. And our next speaker is going to be Professor Dimakatso Lebina, who is she's now moved from PHRU. She's since moved to, she's a director of clinical trials at IDORI, which is headquartered in Durban. Over to you, Prof.
Sure. Good afternoon. There were much fewer people when I came in, so I had hope that I'll be talking to a few friends. But the room has filled up, and thank you for allowing us to come and share the work that we have done previously before COVID. And as explained previously, we were looking not only at an individual level intervention. This was a cluster randomized trial, also looking at the impact at the clinic level, with the aim of trying to increase the number of people that are investigated and the number of people diagnosed with TB. As we had said, I think currently about a third of people are neither diagnosed or initiated on TB treatment. So we were looking at the impact at the clinic level, and we tried to include clinics that are diagnosing 15 or more TB cases per month. However, as we started looking, there were very few of those. We then included those that are diagnosing 10 cases or more per month, and we had 143 that qualified in the whole, in the 3 provinces, Gauteng, KZN, and Western Cape. And we then chose 8 in Gauteng, 26 in KwaZulu-Natal and Western Cape, and there were quite a lot of strict criteria on which clinics they shouldn't be doing any other TB studies that could interfere. They should also not be too close together, and we also excluded those clinics that were diagnosing quite a large number of TB cases. And one of the wonderful things with implementation science research is that you do it in real life, and life happens. So after all that selection and criteria and thinking, we found the best clinics, 2 clinics bent down. 1 clinic before we started, and 1, I think, about 2 months into implementation. 2 clinics, as we started implementing, we realized there was actually another study being done by colleagues from NICD that was too similar to what we're doing and could possibly interfere. So at the end, we ended up with 62 clinics, but some were not included in the analysis. So 30 were included for control and 32 in the intervention. So these are the number of clinics per intervention by province and also overall. So we had 32 clinics intervention, 30 control across the 3 provinces. We also struggled with the approvals at the various levels, so we did not start at the same time, but we started within 6 months. And as we were also implementing, the aim was to try and do 12 months in each facility. Then we also had the challenge of COVID-19. So in some of the clinics, we had to stop prematurely, and we didn't continue after the disruptions of health services due to COVID-19. But we were in the clinics for a median of about 12, 11 months. In the controls, it's easier because we're not intervening, so we could collect data for the entire period. And as you can see on the last row, the median number of TB patients diagnosed each month prior to the study start it was more or less the same, whether intervention clinics or control clinics. If you look at overall controls, it was 15, and interventions, it was 16. But the clinics were also then categorized between small, medium, and large in terms of randomization, to also make sure that there's representation of all the three groups. So the results, rate positive per month, changed. We'll start with expert. So the first two columns are looking at pre-trial period, and then the last two columns are looking at trial period. If you look at expert in the intervention clinics, prior period, 15.6% of people investigated for TB. This is based on data from the lab. Were then found to have TB in the control, 16.3, and then during the trial period, you can see in the intervention arm there's a slight improvement, but in the controls there's quite a drop from 16.3 to 14.7. And if you look at culture, a similar pattern of an increase in the intervention from 4.8 to 7.4, control more or less the same. And the number of people diagnosed or proportion for men, 12% in the intervention prior to the trial, and that remained more or less the same. For women, it increased slightly, which also shows that if you do any interventions that target people that are already at the health system, you are most likely going to reach more women than males. There was no change whatsoever for children 0 to 14 years, as maybe most of them were not being identified in those risk groups. But in terms of age group 15-45 and 45 older, similar pattern of a slight increase at the clinic level, median number of people diagnosed or proportion diagnosed as having TB. And looking also at the various clinics, in the first diagram, you have the number of clinic, or a number which represent each clinic, and then at 0, it's a sort of midline, and then minus is prior to clinical trial, and then an increase as we do the trial. And you can see in the standard of care clinics, most clinics diagnosed fewer cases of TB post the intervention, and some remained more or less the same, and a few clinics diagnosed more cases compared to prior to the intervention. Whereas in the intervention clinics, you have more clinics that diagnosed more TB cases prior to the implementation of TAD. And that's summarized in the table, with about standard of care dropping by about 1.5 cases per month, and the intervention increasing by 1.2. And these are sort of small numbers, but if you also look at the stratified adjusted results by province and by clinic size, as well as by gender, and whether expert or liquid culture results or overall, you can see in all the stratified variables in the control arm versus the pre-study, looking at one as where there's no change. In the control arm, pre-study, comparing pre-study to post-study, they diagnosed far fewer TB cases by looking at all the stratified variables, whereas in the intervention versus control arm, whether it was large clinics, medium clinics, or province stratification or gender, there were more TB cases diagnosed per month compared to prior to the implementation of TAD. And summarizing then that adjusted for prior period and clinic volume and province, overall 14 more cases were diagnosed in the intervention clinics, or the clinics that implemented the TAD intervention, compared to those that did not implement it. And when one looks at the overall decline of about 8% in the control clinics, then the sort of overall increase in number of TB cases or median number of TB cases diagnosed per month per clinic, comparing prior period or the standard of care phase, after comparing that to the third implementation. There's a 17% increase in the number of cases diagnosed by clinic per month. So that sort of summarizes our presentations, or the third implementation, that if one implements systematic screening with expert and or culture, which is what we're doing in this study, we're sending both for expert and culture. Overall, based on those three risk groups, you have 6% of people that might not necessarily be presenting at a health facility with symptoms that might warrant a sputum investigation for TB. But if you investigate them irrespective of their symptoms, 6% will be test positive for TB. And if you only focus at those that are living with HIV, 5% will have TB. But considering that month to month or year to year comparison, in general, clinics are diagnosing fewer TB patients per month. We saw this 8% decline in our study clinics, whereas in the clinics that implemented TAT, there was a 17% net increase in TB cases diagnosed per clinic per month as compared to the standard of care clinics. And we therefore propose that systematic screening with expert is recommended in these subpopulations that are at high risk for TB. Thank you.
Thank you, Prof. Lebina. Just a reminder to jot down your questions so we have a robust discussion at the end. Our next presenter is going to be Dr. Mamapudi Kubanje, who works at HERO. She's an epidemiologist and infectious disease modeler, and excited to listen to her talk as a recent graduate from UCT. Over to you, Doctor.
Okay. Hello, everyone. Thanks for having us to present our work on TB. I'll specifically be talking about modeling TB. So just to give a brief background on the stats on TB in South Africa, so we have about 300,000 new cases developing each year in South Africa, and about 55 people dying of TB. And as Neil and Violet earlier highlighted some of the risk factors, HIV is the most potent. Other risk factors include diabetes, undernutrition, and smoking. And these are also distributed differently by sex, but with well known that TB is much higher in men than female. We also know that TB is a social disease. It affects those who cannot afford and live in poor conditions. Over time, South Africa has implemented various strategies to control TB. Historically, when we do some analyses, most of the impactful interventions are ART for people with HIV and increased screening and testing. With the emergence of COVID, we've seen some bit of regression in the efforts, with slight reductions in the rates of declines, and also slight increases in mortality. And so the prospects of meeting these TB targets that we just highlighted are very uncertain. So the South African National TB Program has aligned with the NTB strategies outlined in our national strategic plans and the National TB Program as strategic plan. And some of the interventions that are currently suggested or highlighted to be implemented include the TAT for newer screening strategies, and also screening at household level and community level, and also improving some of the regimens, shortening preventative therapy, and also for drug-resistant TB. So the work that I'm going to be presenting is some of the preliminary results from modeling the impact of some of these interventions that have been implemented. So how we go about with this analysis, we use a dynamical mathematical model that simulates the South African TB epidemic and simulates various target populations, and then we also estimate incidence and mortality, and some of the other outcomes include life years lost and disability adjusted life years. This work also included some engagements with stakeholders that informed us about the interventions that we include in the model and the coverages that are deemed feasible. We also used input costs from various costing studies that are done at the Health Economics and Epidemiology Research Office, and we then calculate the total cost using the target populations from the model and the input costs, and then we do the cost effectiveness analyses. And so these are some of the scenarios that we simulated. So NSP is what the NSP working group suggested to be included in the TB program for 2023 to 2028. And we also simulated the hypothetical scenarios, including targeted universal testing. So in these, we are maximizing. So in the household context, for example, we assume reaching all of them. For people with HIV, we also reach all of them. And for people with a history of TB, we also reach all of them. And the others is door-to-door screening. You do symptoms screening and then expert if you're positive. And then we have digital chest X-ray. If you are positive, then you get an expert. And then the last one is combination of expert and NSP. Okay, so this slide just summarizes some of the impact that come out of implementing the individual interventions under the NSP. What we can see or say here is that under the targeted universal testing interventions, targeting household contacts is the most impactful. And in the other screening interventions, targeting or screening at public health facilities, and also screening people with household contacts are the most impactful. And in this table, we also show the most cost-effective interventions from the most cost-effective to the least. And as I mentioned, so targeting household contacts and improved linkage to care, and also expert at health facilities. And in the, so this is a very busy slide, but this is summarizing those interventions that I highlighted earlier. Looking at the figures, what comes out is that the NSP, so the NSP and the targeted universal testing, if they're maximized, they would lead to the most impact in reducing incidence and mortality. But if we look at the NTB milestones, which we're trying to reach about 90% reduction and 80% reduction in incidence and mortality, we're still way far from reaching them, even if we were to maximize these interventions. And also, as you can see, in the cost effectiveness analyses, these interventions, the NSP and the targeted universal testing come out as the most cost effective, but they're quite, they require a lot of investment in funding as well. So given that we are not reaching these interventions, and to date, all of these interventions we've been looking at are biomedical, so diagnostics and treatments, but we do know that TB is a social disease, and more recently there have been like traditional studies coming with evidence showing that, for example, supporting patients with TB improves outcomes, and also providing households with nutritional support does reduce incidence in households. And also globally and at an ecological level, we have seen that with improvement in economy and development, the incidence does reduce over time. So it does suggest that we do need to also consider some of these socioeconomic interventions in our strategies. So as we've seen in most of these and results, that it's still going to be a long way to meet the NTB targets, even if we were to maximize some of these interventions we have. We do have some innovations on the pipeline, for example, diagnostics and also vaccines. But for example, currently we still have about 6 trials in phase 3, which are only going to be getting our results in 2028. So we're going to have to wait until then to know if it would work. And with diagnostics, we're still having the challenge of getting the most specific and sensitive tools, which are very accessible and cheap and less complex. So it's still have a long way. So in the time being, we could also look at the risk groups that Neil mentioned earlier, and also address some of the socioeconomic conditions to NTB. Yeah, I think that's it from me.
Thank you, Mama Kudi. Always nice to hear how the modelers then use all this data and make us understand what they are doing. We appreciate the efforts. Our next presenter is Lara Noble, who is a medical scientist at Wits Diagnostic Innovation Hub. She works across infectious diseases diagnostics, and her talk is going to be on the new innovations in collecting samples for TB testing. Over to you, Lana.
Hi everyone, thank you. Okay. So I'm presenting a lot of this data on behalf of Anura David. She's really the driving force. We call her our swab queen. You'll understand why shortly. And obviously Prof. Leslie Scott, who leads the R&D program. So what we are going to discuss today is looking at options for scaled testing for TB. So just briefly in the background, I know you've heard quite a bit about the background, but South Africa's always been a leader in TB diagnostics since early this century. We were the first to roll out molecular TB testing, and that was with the Gene Expert program in 2010. And then when Cepheid, who supplies the expert assay, rolled out the Ultra assay, which is just a more sensitive assay looking for TB, also with rifampicin resistance, we were globally the first to switch to that. And then most recently, our national program has switched to a tiered TB testing option. So we have our lower volume. Is this going to? No. Oops. Okay. We won't try that. We have our low volume Cepheid, which is split across a number of clinics. Then our medium volume testing clinics, so where you have hubs sending the specimens through for testing, they use the BD Max platform. And then for the really high volume clinics, we leverage from HIV and are using the Roche platform. And the latter two also include ionized resistance as well as rifampicin. So we really are doing a great job at diagnosing TB, but we are still missing a large number of people outside the lab. So how do we get these so-called TB missing millions into the lab? So what we need to do is to increase case finding. So as Neil really stated, reduce that pre-care seeking delay with active case finding, and then can we scale testing just to really screen as many people as possible? Ideally, could we screen the whole population relatively regularly? So the first option, instead of coughing up that oyster, as Neil described, or coughing and producing saliva, is the tongue swab, which is one of these, quite a small little swab. And studies have been ongoing with these for around 7 years now, but really became very popular during COVID when there were nasal swab studies after the oropharyngeal swabs that I'm sure a lot of people remember. And one advantage of COVID is it really opened up the idea of self-testing and self-collection and alternative specimens, such as the tongue. So there have been a number of studies ongoing globally. So some of Anua's partners. And then this tongue swab, we take into the lab. It's been optimized to use with all of our current platforms, with elution in TE buffer, heat inactivation, and then straight into the assay, which Cephid had shown there is cartridge-based. The others are also pretty automated. So these studies, there's a lot of talk about them at Union Conference last year. They really have been a lot of investigations. How do we get the TB bug broken open if we are not using a magnetic bead extraction, which is expensive? We want to bring down the cost. So as you can see down here, there's talk about bead beating and lysis. That's really just to crack open the TB bug, because it's something that doesn't want to be broken open. A lot of our other infectious pathogens are more easily to break open. And this systematic review showed the different studies. There's really been quite a variety of success. Specificity overall has always remained very good. We must remember this is molecular, so we're looking for very specific pieces of the TB DNA, so we expect specificity to remain high. Sensitivity, however, has been a little up and down, ranging from in the high 90s, which is where we like to see it, down to around 70%. So we say this really, at the moment, we can't take it beyond screening, but it's great if we screen hundreds or thousands of people and we find a few hundred extra TB cases. That's great. We may still need to rely on what's existing and possibly sputum at this stage. Long term, we're hoping not, but to make a diagnosis before we put someone onto treatment. And what these studies have said is it's very acceptable to the healthcare workers who collect in the specimens, as well as to patients. And in the labs, there hasn't been much of a worry having these instead of the sputum, which, as someone in the lab, I really hate those little oysters that come through. Okay, then as part of, it was linked to the TUT study, there were some further investigations on the healthcare workers, and also healthcare worker collected swabs versus self-collected swabs, and that's a tongue swab. As you can see, it was just a subset of the participants, and we compared it to a sputum ultra result. These were also tested, the swab was tested on ultra as well. And between healthcare workers and self-collected swabs, there was overall very good agreement, 84%. So we are working on improving that with better videos, better collection modules. But the healthcare worker perspectives, yes, they prefer tongue self-collection for safety reasons. You don't have to don your protective gear and then explain to someone how to cough, and now they cough into a sputum vial, but obviously when you cough, you're supposed to cough into your elbow or your hand. Now you cough into the open air. So that leads to aerosolization. It's also a much quicker swab or specimen to collect, because you just swab your tongue for 30 seconds. They have put together some guidelines. You shouldn't eat for 30 minutes before, shouldn't drink for 30 minutes before. If you can do it early morning after you've been breathing and possibly coughing into your mouth all night, that's the best swab we can get, which is then obviously best with self-collection, because you wake up in the morning, pick up your tongue swab that you've got next to your bed, swab your tongue, and then you bring it along to the drop-off point of the clinic sometime later in the day. They can be transported at ambient temperature. And it's easier to package for transport. That's partly because if you look at this is a sputum cup. It's quite big, and you've got this gooey sputum plus saliva in it. If you don't close it properly, that's now going to be all over your sample transport bag, which is not ideal. The swabs are a little easier because you rub it all over your tongue for 30 seconds. I won't put you through the process. but then it's going to still be, the swab itself will be wet, but nothing else will be wet. And then it just simply gets broken off into a little collection tube, which is then sealed. And it actually captures the swab inside. So unless you open it, nothing's going to come out. And these are easy to rack up or put into small transport bags. So it also does assist courier costs. Another part of this, which is quite critical if you are screening people who are not showing symptoms of TB, if you're going out into the community, you need to find a way to call people with a positive result back for further intervention. So most of the tubes that we use are barcoded. And what we're showing here is the idealized situation, which we are working on for the Touch Plus study, which will be that the barcode gets scanned and then tracked the whole way through, including in the lab portion, and then that result can be returned either to the healthcare worker to follow up, or in the longer term, directly to the participant, not to say, oh, you have TB, you need to do something, but just please return to your clinic, or alternatively, you don't seem to have any signs at the moment, please continue to monitor, here are some things to look out for. So the Touch Plus study is a cross-sectional study we're doing with PHRU and a lot of other collaborators there. It's cross-sectional, and we will have about 10% of those swabs paired with an actual sputum. That will be random. So for high throughput testing, we were introduced to the Nexar platform by the Gates Foundation. This platform has been used very widely in agriculture for a number of years. And the beauty of this platform is it can test thousands of specimens at one time. In agriculture, they do about 100,000 a day. We're looking at closer to 15,000 a day. So if we can get those tongue swabs in, we can really feed into this platform. It also is ideally lower waste because we test in what's called an array tape, and I seem to have forgotten to put that out. It's a little tape, so instead of using piles and piles of PCR plates, you have your reaction in a small tape, and the reaction volume is 5 microliters. It's also an open platform, so the longer term idea would be to add on different resistance markers. You could also add on flu markers, and off that one specimen test beyond TB if you want to. So we are currently optimizing the TB assay. We have shown it with COVID, we have shown it with flu. Those were provided. Now we are moving on to TB. It's an endpoint PCR. It's water bath based. Those tapes, 28 tapes at a time, get wrapped around a basket, and old-fashioned water bath based PCR with endpoint fluorescence. And what we've done here is just divided up into 4 quarters. We have 2 TB markers on it. You can't hear me, oh dear. And I can't work the pointer. Every button was doing the wrong. Okay.
The red one here.
The red one, okay. Perfect, thank you. Okay, so we have 2 TB markers, insertion sequence 6110 and 1081. Having 2 markers is just in case there's a mutation in one of them that affects your specific sequence but not the actual pathogen. It's better to have 2 insertion sequences. And we also have an endogenous internal control, which is RNase P. And that's just to ensure, because we received this dry swab, we don't know if someone's actually used it or did they just wave around in the air. So the RNase P allows us to control to know that it was actually used on a human. So what we find is here is where our TB positives come up, mainly our controls. Every once in a while you'll get a TB positive without an RNase P, but those would be the really high ones, just where it overwhelms the reaction. We do have dropouts down here. That would be those ones that haven't been used properly. And then our RNase P only, those are obviously TB negative. And then up here we have our dual positives, which are positive for both, so that we can tell quite easily what is happening. And we get that out as an Excel spreadsheet, which we then use our fabulous data scientists to take further. So compared to the Ultra, using contrived TB specimens in this case, we took sputum culture and we then diluted it. We have found that it can detect down to approximately a low Ultra on sputum. So we are investigating that further. I'm going to start with 2,000 actual real patient specimens now, and next year hoping to scale that up if our results are as we want them to be, and that we can find multiple TB positives within the community. And I think that's it for us. Thank you.
Thank you, Lara. And so this was our last presentation. And just to give our presenters a round of applause before we open up for questions. I will open up the floor for discussion. So if there's anyone who has questions, otherwise I can kickstart, but I would rather open the floor for discussion because I've heard these talks several times. Questions? Maybe whilst people are thinking, I'll quickly summarize what the discussions were about. So we started off with the End TB strategy and clearly showed you where we need to be by 2035. And as countries are really thinking through what options are there for us to accelerate these strategies so we meet the 2035 targets, there's been a lot of interventions that have been evaluated in South Africa. So that we heard about the TAT presentation. If I take you back to 2011 when GeneXpert was introduced, we only had this one diagnostic test that was thought to be the magic bullet. We were going to find TB cases, but obviously there was something that we were not doing correctly. And so these strategies are aimed to try and accelerate implementation of those. And we've just had the last presentation really showing us the diversity of tests that are now available. So it's no longer just the Expert Ultra available. We have other alternative tests available for different levels of laboratories. So clearly a lot is happening. And the modeler kind of dampened our spirits when she said we are unlikely to meet the 2035 targets. But I strongly feel there's 11 years to go, so still more can be done. So I'll open up the floor for discussion.
Thank you very much. And I really appreciate the talks, all the 4 talks that we've heard this afternoon. I'm particularly interested, I'm intrigued, when we speak incipient TB and then we speak the subclinical TB and the various, I can say, associated factors or risk factors. With the previous TB, the previous history of TB, I think I would like to know, and I've always asked myself, but I don't have the answer, why are we picking the 2 years? We say that if there's a history of TB in the last 2 years, perhaps from a basic science perspective, I'm not sure where the explanation would come from. Thank you.
Thanks for the nice talk, speakers. I just have 2 questions. The one thing is that can you comment on the TB resistance patterns that we're seeing and how we respond to that over time? And then maybe you can give us some insight into how the current vaccines that are in the clinical trials, how they're performing. Thanks.
So my question is to Prof. Martinson, just with regards to the TB diagnosis over the last 2 years and using a molecular PCR-based technology, wouldn't we be just identifying non-viable bacilli in patients who may or may not be having active or viable bacilli? So how do we mitigate against that particular, concept, or how do we mitigate against that? Because I think that's what's coming up in the discrepancy between your liquid medium positivity and your PCR-based positivity.
So just to respond to the first question about prior tuberculosis, why did we choose a cutoff of 2 years? So a large proportion of people in South Africa have had prior tuberculosis, and we were trying to target people at very high risk of TB, and a guy called Florian Marx had given a talk, and I think he's published his work by now, which showed that the real risk for people who had prior TB was in the first 2 years of stopping their TB treatment. And so that was why we arbitrarily included 2 years. I think similarly, there's data not from South Africa but from the Netherlands, which showed that people who had been a household contact by about after a year of being exposed to a household contact, about 80% of people would have developed TB, and so we also restricted that to 1 year after household contact. But I mean, it is fairly arbitrary, and it's it could be extended depending on how much money you're willing to throw at testing. But certainly, people with prior TB are at a huge risk of subsequent tuberculosis. And then maybe I can just talk about the viability and molecular testing. So clearly molecular testing doesn't evaluate viable bacilli, but it does give you a sense that there's the bacilli there. And there's quite a few studies which have shown that molecular tests can remain positive up to 2 years after an episode of TB. Now, in our TUT study, we showed that it was very high concordance between liquid culture and molecular test positive. In fact, I think about 80% of the molecular tests being positive were supported by a culture if you excluded the trace. So I think that the benefits of the molecular tests in their rapidity and accuracy and getting a result almost immediately really outweigh the few people in which there'll be a false negative or a false positive.
And the recommendation from this study was that even if somebody is positive on expert, if there were previous TB, they should still have a positive culture before they can be initiated on treatment. So it could still be looked at a two-tier step to say you do the expert, if it's positive, then culture. In some provinces, they actually sent 2 specimens at the same time, one for expert and one for culture, especially for previous TB.
The other question was around resistance and drug resistance. So, Lara or Neil, do you want to tackle that one?
On the data, looking at clinic by month, the rifampicin resistance did not change even as we were implementing TAD. So implementation of TAD did not necessarily increase the number of people diagnosed that are rifampicin resistance. It was very similar in the intervention and control and comparing prior period and during the trial period. So it hasn't changed much. Even I think on the general South African data, it's still more or less the same. What has improved is the treatment.
Yeah, I think, and then I think in South Africa about 6% of all tests that have been done to look for rifampicin resistant are positive. So approximately 6% have drug-resistant TB, and I think that has stayed relatively common. And even in our study, it was relatively common. And the thing about resistance is that it's been detected earlier, much earlier than it used to be detected with these molecular assays that have the capacity to do resistance testing immediately. Because in the bad old days, we used to wait until someone had got to like 4 or 5 months of their TB treatment before we did a sensitivity test if they were not responding to TB treatment. So once again, people had to earn a test for resistance before we intervened, and that obviously had very bad implications for the people who were diagnosed with resistance.
Unfortunately, we've come to the end of our session. I'm getting signs that we are running over time. However, there's a networking opportunity, so if people have questions, you can speak to the presenters directly. Thank you everyone for attending, and thanks to our fantastic speakers.